a quick review, the pharmacology of sedative hypnotic drugs. Darkness is going to stimulate the production and release of melatonin from the pineal gland. The melatonin is going to stimulate two types of receptors, melatonin type 1 and type 2. These receptors, they are a G protein coupled receptors, which mean they are going to span the cell membrane 7 times, as you can see it here. The melatonin type 1 receptors connected with adenyl cyclase in a inhibitory manner, so it's going to inhibit the activity of adenyl cyclase and decreasing the production of cyclic AMP. And the stimulation of this receptor is responsible about the regulation of the rapid eye movement sleep. The type 2 receptors is stimulation of the type 2 receptors is responsible about increasing the non-rapid eye movement sleep, which means that is going to increase the stages of 1, 2, 3, and 4. The melatonin receptor agonist, I'm going to mention two of them, ramiltion and tacimiltion. The ramiltion, this medication working as an agonist by stimulating the melatonin type 1 and 2 receptors, mainly used for those who have difficulty in falling asleep because it's going to reduce the time that will be spent from getting to the bed until we'll be getting into a real sleep. This medication is effective up to 6 hours, comparing with the melatonin, which is effective only for about 2 hours. And it is almost like 10 times more potent than the melatonin in promoting the sleep. This medication has no effect upon the sleep characteristic or pattern, will not produce any rebound insomnia, also will not produce any significant withdrawal symptoms. This medication will be metabolized by subtypes of cytochrome B450, so it should not be combined with the inhibitors of these subtypes of cytochrome B450 because that is going to accumulate the drug. Now, some of the side effects for this medication: dizziness, drowsiness, fatigue, and since melatonin is going to produce some changes in the endocrine, so this medication also is going to produce some endocrine changes. The second melatonin receptor agonist, tacimiltion. Now, this medication is working as an agonist upon the melatonin receptors type 1 and 2, but having a greater affinity for type 2. The main utilization for it in the management of the non-24-hour sleep-wake disorder. It's supposed to be given 20 milligram daily at the same time every night. And the drug effect might require weeks up to months until it will be producing the beneficial effect. Don't give with the cytochrome B450 1A2 inhibitors or cytochrome B450 3A4 inducer, because that is going to accumulate the drug or to decrease its effectiveness. Now, the major side effects or toxicity will be producing headache, nightmares, which are terrible dreams, and fatigue, Beside that, it will be increasing the incidence of the upper respiratory tract infection and also the urinary tract infection. In this slide, I'm going to describe the non-24-hour sleep-wake disorder, which it is a circadian rhythm sleep disorders. Let's take an example. In this individual, we have the patient will go to the sleep at midnight and will be sleeping for about like 6 hours. So he's going to wake up in the 6 a.m. in the morning. Now, if the biological clock fails to synchronize to a 24 hours per day, so now this individual, instead of going to sleep at the same time every day, he will be shifting now the sleeping hours. Now let's take for an example, we'll be shifting the sleeping hour. It might be delaying for minutes up to hours. So it might be, for an example, 24 hours plus 10 minutes or 20 minutes up to reaching up to 24 hours plus up to 6 hours. Now, in that condition now, the patient will be shifting his timing to sleep. Let's take an example that he is making a cycle of 24 hours, 25 hours. So now in this condition now, every night he will go to sleep delaying for 1 hour. So, and also will be wake up about like another 1 hour later. So now you can see it here that how he will be shifting the sleeping hour. And now you can see that many of his sleeping hours, it will be around noon. Now, because we put it to 25 hours, so he will require 24 days until he will be returning back to the normal that he will be going to bed at midnight and will be wake up at 6 o'clock. And then he will be repeating that again and again. Now, here you can see it now. During this time from 6 a.m. up to midnight, it will be the usual activity of the other human being, let's say. Now he is cutting that. He is unable to synchronize with this activity. So he is taking now majority of it. It will be majority of his time. It will be sleeping. And if he is trying actually to fight against this internal rhythm, and sleep, he will be having a severe and cumulative sleep deprivation. Now, this incidence is happening about like 55% to 70%. It will be happening in those who are completely blind people because they have an absence of the environmental cues. And the Tessie Milton is just whenever we give it every night at the same time, is trying to return back to the normal cycle. That's the normal cycle, which it is a 24-hour sleep-wake cycle. In the hypothalamus, we will find orexin neurons. They've been estimated to be about 70,000 neurons. They are producing small peptide, orexin A 33 amino acid and orexin B 28 amino acid. This area produce projection to different nuclei in the brain and sending for them these orexin A and B. Now, these will be interacting with a different type of orexin receptors, type 1 and type 2. So in type 1, that will be present, for an example, in the leukocereus, where we do have the production of norepinephrine. Type 2 receptors, it will be found in a different area, and the combination of type 1, type 2 receptors will be found again in a different nuclei. So the orexin will be working on these receptors to finally to lead to an arousal and wakefulness. So if you are going to use now a medication that will block these orexin receptors, like the suvorexant, so we are going now to block all these nuclei activity, and that will be leading to a decrease in the arousal and wakefulness, and will be leading to sleep. So this medication, suvorexant, will be decreasing the time to go to sleep, and also will be increasing the total sleeping time. So we are using it for those who are suffering from unable to go to sleep, and also to maintain the sleep. It's considered to be category C during pregnancy, and it will be given starting with a low dose 10 milligram once daily, will be given 30 minutes before going to the bed. The side effects will be producing nightmares, sleep terrors, abnormal dreaming, and also the patient will be feeling drowsiness the next day. Abuse by Ron. This medication is a partial agonist at the serotonin receptors type 1A. It will relieve anxiety without producing any marked sedation or hypnotic effects. Has a minimal abuse liability. The anxiolytic effects take about like 3 to 4 weeks to be established, and usually we use it in generalized anxiety state, and considered to be category B during pregnancy, so it is considered to be safe to be given during pregnancy. Now, this medication will not be having any anticonvulsant or a muscle relaxant properties, will not be interacting with the GABAergic system, will not produce any rebound anxiety or withdrawal signs if we discontinue it suddenly, and it will not be effective in blocking the acute withdrawal syndrome, which will be result from stopping the benzodiazepine or other sedative hypnotic drugs, and it will not be producing any effect on the driving skills. Besides, it will not potentiate the effects of the ordinary sedative hypnotic drugs or ethanol or tricyclic antidepressant, will not be potentiating their effects. This medication will be given just like 7.5 milligram orally 2 times a day, starting initially. It might be increased. The adverse effects that will be happening in about like 10% or more of the cases, it will be dizziness and drowsiness. The antidepressant, which is used in the management of insomnia, we have 3 drugs. Doxepin. This medication will block the reuptake of serotonin and norepinephrine, and also will block the receptor for histamine type 1. It might be increase the suicidal risk. Given either as 3 or 6 milligram once daily, the dose supposed to be given within about 30 minutes of the bedtime. It might be produce some side effects as dry mouth, blurred vision, constipation, and urinary retention. Trazodone will block the reuptake of serotonin, and will be working as an antagonist upon serotonin type 2A, and also will block the histamine receptors type 1, beside also blocking the alpha-1 adrenergic receptors. It's been used off-label in the management of insomnia. However, now the American Academy of Sleep medicine guidelines for the treatment of chronic insomnia suggest that it should not be used because there is insufficient evidence for its activity. Mirtazapine, this medication will be working as an antagonist upon the central presynaptic alpha-2 receptors and also antagonist upon the serotonin type 2 and 3 receptors. Besides, is going to block also the histamine receptors type 1. This medication also, it might be increasing the suicidal risk. And finally, just will mention about the antihistaminic drugs that will be used in the management of insomnia. So we have a famous drug, diphenhydramine. However, this drug is going to raise the risk of dementia with chronic use, specifically in elderly. So for that reason, the American Academy of Sleep Medicine guidelines for the treatment of chronic insomnia suggest that it should not be used because there is an absence of evidence for clinically significant improvement beside the toxicity that it might be produced. Doxylamine, this medication will reduce the difficulty falling asleep, supposed to be given about like 25 milligram once daily within 30 minutes before the bedtime, having many side effects because it's blocking the histamine receptors and also the muscarinic receptors. However, all of these antihistaminic agents should not be used more than 3 to 5 days as in the management of insomnia, because they are going to produce a lot of side effects and toxicity. And here just will mention one thing also, that these antihistaminic agents, they might be produce excitability actually in the small children, in the small kids, so they should not be used. They might be produce an excitation instead of inhibition and drowsiness.